Today I'll be talking about renal cell carcinoma, also called RCC. Renal cell carcinoma, or RCC, is the 8th most common cancer in the United States, and it's usually the most common incidental found cancer due to various MRI or CT scans you might have for any other reason, such as a kidney stone would find an incidental finding of RCC. Early RCC detection obviously gives excellent prognosis, so these incidental findings usually stage RCC in very early stages, giving you the best chance of survival from diagnosis. There's 4 different types of RCC. You have clear cell, papillary, chromophobe, and oncocytic. Our patient Mary has clear cell, which is the most frequent type of RCC. The risk factors for RCC is you are more likely to get it if you are male, if you have hypertension, you smoke, you're obese, or you have inherited predispositions such as von Hippel-Lindau or Birt-Hogg-Dubé syndrome. Men are 1.6 times more likely than women to get RCC, and with von Hippel-Lindau, it suppresses the VHL tumor suppressor gene and causes various clinical manifestations that lead to RCC, such as retinal angioma and central nervous system hemangioblastomas. And then here are the list of different hereditary RCC syndromes, such as von Hippel-Lindau, hereditary papillary renal carcinoma, Birt-Hogg-Dubé, and 3 others. But our patient Mary did not have any hereditary RCC syndromes. The symptoms for RCC, again, most masses are incidental findings because the patient tends to be asymptomatic when they find it so early on. The clinical triad, which is usually what's looked for RCC patients, is hematuria, which is blood in the urine, abdominal pain, or a flank or abdominal mass. But this is usually only found or seen in 5% of cases because so many are diagnosed early on. There's also the symptom of anemia and weight loss. Our patient Mary presented to her doctor with abdominal pain and weight loss. Now, Mary's abdominal pain led to diminished appetite, leading to her weight loss specifically. For tests and imaging for renal cell carcinoma, the evaluation of the mass usually begins with a CT or MRI of the abdomen. The MRI usually offers a more detailed evaluation of whether the tumor has invaded other various parts of the kidney, such as the renal vein, or if it connected to the inferior vena cava or aorta, usually indicating a farther along cancer. Then it's usually followed with a CT or X-ray of the chest because RCC easily spreads to the lungs. Brain imaging is rarely done in patients, usually only those that are showing symptoms of focal weakness or confusion, which would suspect that it has somehow invaded the central nervous system. But again, not a frequent test. And then there's labs and needle biopsies as well. Biopsies are not even done in every case. It's really only for those who have suspicion of RCC without a scan actually confirming RCC. Our patient Mary had both CT of the abdomen and chest, and her labs consisted of a complete blood count, calcium levels, creatine or kidney function levels, and liver function tests. For the staging, we can see that as the tumor grows in size, or as more lymph nodes are infected, or if metastasis is present, it affects the overall staging. Our patient Mary, her primary tumor was a T3, so it had extended a bit, but not too far beyond the kidney. There was no lymph node metastasis and no other types of metastasis, so she fell in the stage 3 category. But cure rates for stage 1 and 2 RCC are actually higher than 90%. And then just here is a visual image of the staging so you can get an anatomical view of what it would look like. Stage 1, as you can see, is a very small, centrally located, less than 7 centimeter tumor. Stage 2 has grown a lot, encompasses more of the kidney. Stage 3 has affected both the kidney, the tissue surrounding the kidney, possibly involving some lymph nodes most of the time, usually spreading into the vein occasionally. And then stage 4 is beyond the kidney, beyond the outer lining, into lymph nodes, and usually additional metastasis. One of the most common treatments for RCC is surgical resection, which is usually started with, especially for early stage cancers, this is the way to go, is surgical resection. It usually starts with, or the best, most common, is radical nephrectomy, which is removal of the entire kidney, the Gerarda's fascia, which is just the connective tissue around the kidney and adrenal glands. It also removes the ureter, the adrenal gland on that located with that kidney, and adjacent lymph nodes as well. That again is the standard of care. Our patient Mary had a partial nephrectomy, which is a removal of the tumor and a rim of healthy tissue, trying to leave as much of the nephron of the neuron or the nephron of the kidney intact to allow for proper kidney function. This is the preferred alternative, but is not able to be done in every case. And then there's also patients who qualify for an ablation, which is when they place a needle in the tumor is frozen or heated, and it kind of kills the tumor that way. But 1/3 of patients will develop disease reoccurrence after this surgery, so further additional treatment is needed. Here is a visualization of the pathway for renal cell carcinoma to develop in a human. Again, you can see it's a very complicated pathway, kind of takes a bunch of different routes, and there's 3 different areas where different drug therapies are involved. You will see later on that Mary receives temsirolimus, so most likely her VHL tumor suppressor was suppressed, allowing for growth, or the FKBP12 was suppressed, allowing for additional tumor growth to occur. So again, a quick overview of our patient. Mary, 60-year-old female, never smoked, has diabetes, has hypertension, coronary artery disease. She has pain in the abdomen, 5-pound weight loss. Urinalysis reveals no urine in the blood. Blood tests normal, including liver and kidney function tests. We see really that her only symptoms and risk factors are the hypertension, pain, and weight loss. And she also presented with no change in bowel movements, no nausea, no vomiting, and no family history of cancer. Her primary care physician chose to do a CT scan to look for Mary's discomfort because it had gone on for so long. And on doing this CT scan, they discovered a 12 centimeter mass on her right kidney, which you can see in part A, pointed out by the yellow arrow is the coronal view, which is a slicing through the front of your body. And then part B is the axial view, kind of doing a horizontal slice through the abdomen to show you the 2 different views, but where the kidney, or where the mass is present within the right kidney. For her treatment plan, the doctors chose to do a partial nephrectomy. After this was done, she was placed on a surveillance plan. CT scans were done every 3 months on Mary, and at her 9-month CT scan, they discovered nodules in her lungs. So she, again, was that 1/3 of patients that falls into disease reoccurrence. They did a biopsy on these nodules, and they discovered that it confirmed metastatic RCC. They did lab tests on her to see if anything else was abnormal. Everything was normal, except that she presented with anemia and thrombocytosis or increased platelets, and then she was placed on temsirolimus. We can see in her CT scan, part A is 3 months after treatment. The nodule had not shrunk. Part B is 6 months after treatment. The nodule has significantly shrunk, and Mary has continued on treatment at 12 months, with her most notable side effects managed by medication adjustment.